And as elementary as it sounds, most of us in public safety don't really know when it's appropriate to see a therapist of some kind. Probably the most we've ever gotten on this subject is a pamphlet that someone handed us. So can you give us a little more insight about when we should take notice of something that's happening in our lives that should cause us to talk to a professional?
Excellent question, Ralph. After a critical incident like a line of duty death or the death of a child, a department should have a debriefing where everyone who was involved in the incident gets to talk about their thoughts, their feelings, their reactions, and some normal symptoms after a critical incident. After 2 weeks, if a first responder is still having difficulty with physical problems or with emotional difficulties, then therapy is needed. For example, some physical symptoms common after a critical incident but really difficult to manage for people are headaches, waking up in the morning with a headache because their jaw is tense at night, difficulty falling asleep or staying asleep, or on the other side of the spectrum, sleeping too much, difficulty eating or keeping food down, stomach problems, feeling like you need to eat a Tums after or before every meal, backaches, tension in your muscles, just feeling like you're not yourself. Some emotional problems that people experience after a critical incident might be anger or irritability, feeling frustrated all the time, arguing with the family more so than normal, excessive use of alcohol. Some of these things, if they last longer than 2 weeks, you might want to seek help for that.
A little bit of that we've probably heard before, but most first responders are probably pretty bad at recognizing those symptoms in themselves, or if they do recognize them, they're very likely to think that, well, that's normal, we just went through something kind of tough, and naturally I'm going to get over it. So in light of that, how do first responders really recognize that it is time to see a professional?
Well, that would be a great place for peer support, because often colleagues are the first to notice changes in a first responder. And I really believe that peers need to take care of each other. So if one of your colleagues notices a difference in you, like you haven't been showing up, we haven't been going fishing lately, we haven't been out running like we usually are you avoiding us? If a peer says, hey, something's up, then listen to your colleagues. Listen to the officers that you work with. Secondly, family members might notice these changes in a person. For example, if a firefighter is having trouble sleeping or having night terrors or grinding their teeth at night or having difficulty falling asleep, their spouse is going to know that. Their spouse is going to see that. Changes in the family, different stresses on the family produces behavior change. So if the family members say, something happened, what's wrong? That might be a clue to get help.
Well, that naturally leads to the question of what is therapy? If you haven't been through it, I think people are a little bit scared of what it might be. They're kind of afraid you're going to crack them open and expose every little thing about them that's uncomfortable. So tell us a little bit about what actually happens in therapy.
Well, therapy can be goal setting. So you might come into your psychologist's office and say, I'm having problems at work. You might talk about some of your symptoms. I have headaches, I have stomach aches, I can't seem to concentrate on anything. And for those 50 minutes, you decide on the goals. What do you want out of this therapy? What do you want to be different when you leave here? Because therapy is temporary. Some therapists will ask you to do some homework assignments, like some journaling. They might ask you a question in therapy and the first responder doesn't have the answer. So the homework assignment is to go write about that, go journal about that, about your thoughts, your feelings, your behaviors, the beliefs that you have about yourself. First responders are natural problem solvers. They want to fix things. Therapy doesn't always work like that, so it may be frustrating. Therapy is not a miracle, it's not magic, it's not voodoo. Therapy is a time for you and your therapist to look at your thoughts, your feelings, your behaviors, your symptoms, things that are making life really difficult at this time. Not forever, but at this temporary time following a critical incident. Therapy is confidential. If you see a psychologist or a therapist or a counselor, they can't speak about what you discuss to anyone unless you give written permission. So it's confidential. It's a safe spot just for you to look at your reactions and your feelings and your current difficulties.
How do you find a therapist that's appropriate for you?
Well, that's a good question. Hiring a therapist is not like hiring a painter. You can't drive around and say, look at the good job they did on this house, they cleaned up after themselves, they were there on time. It's a little bit different. The therapist that a first responder picks should fit well with them. They should have what's called cultural competence. They should get it. You don't want a therapist who cannot handle the traumatic events of your incident and your work life. You don't want a therapist who is going to cry when you are talking about the death of a child, for example. You need a therapist that fits with your personality and your style. And every therapist is different. So if you meet one and you don't like them, give them a chance for a while. But if they don't get it, then it's time to shop around. You might ask for a recommendation from somebody, one of your colleagues. The list that your department provides on the insurance will tell you what therapists accept your insurance, not necessarily what type of therapist is a good fit for you.
Anything else we want to be looking for when we choose a therapist?
You want the therapist to be licensed in your state. That ensures a certain level of competence and quality. So you want a therapist that has been licensed. You want a therapist with some experience in your difficulty. Let's say you have an alcohol problem or a drug problem in addition to some work difficulties. You'd want an experienced therapist in addictions. Or perhaps you're having some marital problems. You'd like a counselor or a psychologist that has some experience treating couples. Another thing to consider is the therapist's experience with that particular type of trauma. A therapist might have experience working with sexual assault victims, for example. And if you're working with sexual assault victims, that's a different type of trauma than the critical incidents that first responders are exposed to, involved with in their jobs. You want to look for a therapist that has experience in trauma, specifically the job-related traumas that first responders experience.
What about the notion that no one can treat a firefighter or a police officer or an EMT unless they've been a firefighter or a police officer or an EMT? Is that a necessity?
Well, that's a personal decision for the first responder. The first responder gets to pick their therapist. And if that's important to him or her, then that's a fine criteria to have. Certainly there are a few psychologists who have also been a police officer, who also have been a firefighter. What I tell the veterans that I work with is, I haven't been to Iraq. Is it important for you that I have been to Iraq, or that I have a map to get you out of where you currently are? Along the same lines, some people with drinking problems think that only an alcoholic can help them because only an alcoholic would understand substance abuse. And that is certainly a very personal decision for that first responder or for that alcoholic or addict. And if that's important to that person, that their therapist be addicted themselves or in recovery from addiction themselves, then that's certainly a personal decision that I would respect from a first responder.
There seems to be all kinds of people in the therapy field. I mean, you see different titles and different letters after people's names. How do we know which of those is appropriate for a problem that a first responder might be having after a critical incident?
Very good question. Most people are often confused by the difference between a psychiatrist, a psychologist, a counselor, a therapist, a social worker. So that's a great place to start. A psychiatrist is a medical doctor, a physician basically, who can prescribe medication for emotional difficulties. For depression, a psychiatrist might prescribe an antidepressant. A psychologist is also a doctor, but not a medical doctor, not a physician. Psychologists in most states cannot prescribe medications, so the way they would treat depression would be through therapy. Counselors, therapists are all general terms for people that do counseling. A master's level person can perform therapy. A psychologist can perform therapy. A psychologist can counsel people. A therapist can counsel people. Counseling and therapy are interchangeable, basically. So you can call a counselor a therapist or counselor. You can call a psychologist a counselor or a therapist. But you can't call a therapist or a counselor who is a master's level person a psychologist. Psychologists are doctors. The way to tell if a person is right for you is how you want to approach the problem. Some people avoid medication. They don't want to take medication for their difficulty. So there's no need to see a psychiatrist first for that type of individual. You might start off with a therapist at the master's level, and if you feel comfortable with them and you're able to make changes, if you feel better, if you're acting different and feeling good, stick with that person. If you feel like that therapist does not get it, is not culturally competent, then find somebody else. Ask for a referral. A psychologist is a doctor. You don't need to have a doctorate to do therapy, so it's really a personal decision. What I mean by cultural competence is, does the counselor that you're seeing get it? When you describe how the brains and the blood were splattered all over the wall, do they react or can they hold that type of trauma? When you talk about your shift work or your sleep difficulties that's job related, do they understand that? If you're not seeing a medical doctor and you need medication, a psychologist or a therapist, certainly a master's level therapist, can't prescribe in most states. So the psychologist you're seeing will need to collaborate with the psychiatrist that you're seeing. The psychiatrist you may only visit once a month to talk about the side effects of medication or if you're feeling better or if you're responding to the medication they prescribed. They'll consult with the psychologist that you're seeing because you're seeing the psychologist more often, maybe even on a weekly basis. And the psychologist is a little bit closer to you in terms of monitoring your mood, monitoring your depression, watching to see if your anxiety is less, if you're having less trouble with triggers, if things are bothering you less at work.
What kinds of therapy are there? I mean, when I'm in the market for a therapist, what are my choices?
Well, there's individual therapy, group therapy, and family therapy. Individual therapy is a one-on-one meeting with a psychologist or counselor. Sessions usually last about 50 minutes. They're focused on your symptoms and your current difficulties. Then there's group therapy. Group therapy might be related to a particular problem, like alcohol or addictions, or a divorce support group. In first responder communities, the peer support groups are really important. Then there's family therapy. Perhaps the difficulties in the fire service or in police work are really interfering with family life. Maybe a dispatcher becomes really irritable and arguing a lot with their spouse. Then it might be time to bring the family in, and sessions can be 50 minutes to 60 or 90 minutes. They may be composed of just the couple, or they may bring the whole family in to explain the problem and the difficulty and really focus on getting the family as a system in better shape. Another way to look at individual therapy is by the style or approach of the therapist. we just don't do it all the same way. Some therapists look at attachment and how you're relating to other people. Some therapists take the approach of focusing on thoughts, feelings, and behaviors. Some therapists look at other relationships that you've had either in your past or your present. So the style of the therapist and the way they approach problem solving or symptoms may be different. It's a very personal decision, and you need to ask if they have experience with these types of difficulties. You can ask what their approach to therapy is. You can ask what a typical session is like. Most first responders I work with prefer a very active and directive approach. They're problem solvers. They want to fix this or solve this problem. And they probably won't feel comfortable with a neutral or blank space type of approach from a therapist.
And you mentioned earlier that sessions with a therapist are confidential. Is that 100%, or are there exceptions to the confidentiality rule?
Well, there are some limits to confidentiality. In California, there are 3. Harm to self or others, the abuse of a child, or an elderly person being abused. For example, if you tell me that your mother-in-law can't get her own groceries, for example, and someone is supposed to be bringing her food and she's not being taken care of. In California, we're mandated reporters of elder abuse. If you tell me that you are abusing your child beyond spanking, I'm a mandated reporter for child abuse. If you tell me that you are going to commit suicide today at 4 o'clock with the revolver that's in your glove box, I have to take some steps to make you safe. If you say that you're feeling suicidal, if you say that you would like to die, those are different circumstances. And certainly suicidal thoughts are a symptom of post-traumatic stress disorder or sometimes after a critical incident. So feeling suicidal and doing something about it are different. But if you're actually going to commit suicide, therapists in California are mandated reporters for that. It's called the Tarasoff law. Different states have different rules. California is not unusual from what I understand, but a person would want to check with their state's rules and what limits of confidentiality rules apply in their state.
I think most people in the public safety field think that if they're having problems for weeks after a critical incident, that they must have PTSD. Is that true?
It's possible. One possibility is that they have had too many incidents. This last critical incident was the straw that broke the camel's back. Their bucket is full, and they need some help coping. They need to stop drinking, maybe. They need to get back into their exercise program. They need to get out of isolation. They may have something other than post-traumatic stress disorder. If they have PTSD, PTSD is treatable. Post-traumatic stress disorder is treatable. It is manageable. A bigger problem is the stigma that's associated with post-traumatic stress disorder or problems after a critical incident. And post-traumatic stress disorder is treatable. It's manageable. The stigma associated with post-traumatic stress works out like this. If you are severely burned, people can see that. People notice that. People can see the disfiguration and know this person is hurting. And it's real easy for peers to reach out to each other. It's real easy to pick up the phone and say, when does the cast come off? Or when do the bandages come off? Or when can we come and see you? But if you go out on disability due to stress, or if you're seeking help for post-traumatic stress, isolation is a huge factor. Depression, isolation, and exhaustion. That cluster of symptoms for emergency responders can be deadly. What I tell people about the stigma is, okay, you don't want to tell people you have PTSD. You don't want to get help. Well, they're all going to find out at your funeral if you commit suicide. Just because you have some of the symptoms of PTSD You may not meet the criteria for the diagnosis of PTSD. You can get help for some of the symptoms and not have that diagnosis. And even if you have PTSD, it doesn't have to end your career. You can learn some new tools to deal with some of the symptoms. You can learn some new coping skills. It doesn't have to end your career in the fire service. You can still work as a police officer with PTSD. You can still work as a dispatcher. You can still function. This is treatable. It doesn't have to end your career or your marriage.
So a first responder might not have PTSD.
Well, another way that people in my field are looking at the difficulties that first responders face is a new concept called Emergency Responder Exhaustion Syndrome. This was developed and thought of on the West Coast by the late Dr. Al Benner, Dr. Joel Fay, Dr. Mark Kamina, and Dr. Ann Bruchot. The way we are conceptualizing the difficulties first responders face is by something called Emergency Responder Exhaustion Syndrome. It's characterized by depression, isolation, and exhaustion. Depression symptoms may include lack of interest in sex, loss of appetite, not being able to eat anything, or eating everything in sight. The Doritos, the McDonald's, the junk food. And not being able to sleep or sleeping all the time, weight gain or weight loss without trying, sad mood or anger and irritability all the time. Isolation is characterized by not answering people's texts or not answering your cell phone, getting 300 emails, going into your cave where you just have your channel surfing remote button, or your video games, or www.fillintheblank.com, where you just spend all your time on your computer, on internet porn websites. You are isolated from your family, from your friends, and it takes every ounce of energy to get out and get going during the day. Exhaustion. Everything you do takes an enormous amount of effort. Just showering and making the coffee seems like not worth it, maybe. So exhausted that you simply don't care. Therapists and first responders are vulnerable to compassion fatigue, and this can be just characterized by, I really don't care if you're suffering or if you're hurting anymore. I can't care about my kids' homework. I can't care that we're out of milk. I'm just exhausted and I don't want to do it anymore. So emergency responder exhaustion syndrome might be a better way of looking at some of the symptoms and some of the maladaptive coping techniques that a first responder is dealing with.
I think if most public safety professionals are not feeling well for an extended period of time after a critical incident, they're probably going to talk to a colleague first. They're going to tap that peer network. Is that a good idea? And if so, when should they recognize that they need to talk to somebody beyond that peer network, maybe talk to a professional?
In my research with 3 urban search and rescue teams that were deployed from California to New York following the terrorist attacks in 2001, the peers were actually rated as the easiest persons to talk to about their deployment experiences, both while they were deployed and after they returned home. At the bottom of the list were mental health professionals and chaplains. So I think talking with a peer about your symptoms and your difficulties is a great way to break through the isolation, normalize the symptoms, and get a good handle on what you can expect following a critical incident. Now, after some time, if you're still having difficulty in your marriage or with your family, if you are still not able to sleep at night, if you are still having physical problems like the stomach aches, the headaches that I mentioned, peer support doesn't necessarily affect those positively. So you may want to seek a therapist after 2 weeks if this is just not going away, after you've tried exercise, after you've tried reconnecting with your friends and social network, after you've tried staying away from alcohol for 2 weeks. If things don't get better, then seek help.
Whether or not someone's in therapy, what can they do to make things better for themselves, and what might they be doing that's making it worse for themselves?
Well, some unhealthy coping mechanisms that I see in my practice are, number one, alcohol use. Alcohol use can affect a person's sleep. Most people think if you drink, that'll make you fall asleep. Drinking is the worst thing you can do for sleep, actually. Not being in exercise, not exercising, not having a regular exercise program is really unhealthy. That is the best thing. If you don't want to do medication, exercise is the best thing for you, especially cardio. That can really increase your serotonin, in those chemicals in your brain that can influence a better mood. Being with your friends and being with your family, not going home and watching the TV or being on www.fillintheblank.com, not being on internet porn sites, not being away from people. We're social creatures. We need to be with friends and with family.
Is it only a critical incident that might give rise to the advisability of therapy for first responders?
I would say no. There are 3 types of stress. Critical incident stress is one type. The other 3 types are acute, cumulative, and chronic. So acute stress is a big spike in adrenaline. In Oakland, California, we recently had 4 police officers murdered. That makes the newspaper, everybody recognizes that this was a critical incident. This was a big event. Chronic stress is something that goes on all the time. War veterans coming back from Iraq or Afghanistan have been in combat. They're on duty 24/7, and they never know when the next IED is going to explode. Domestic violence relationships are characterized with chronic stress. They can never let their guard down because they never know when they're going to get abused again. Those are examples of chronic stress. Cumulative stress is everything combined. So it's the line of duty death, then having to respond to the suicide of your friend, then having the ordinary hassles of getting the kids to and from school, then arguing with your wife, then losing the promotion or being passed over at work, then having to deal with that colleague that just really irritates you. That's cumulative stress. Critical incident stress, by definition, overwhelms the ability to cope. It wouldn't be traumatic if you could cope with it. So it's not just the acute stress or the critical incident stress when a therapist could be helpful. A therapist might be helpful in helping you resolve marital problems or helping you deal with a child who has a learning disability or some of the other day-to-day stressors. As the work that first responders do, as that builds up, sometimes it can affect family life. And once the family situation has been resolved or is better, or the whole family has tools to deal with that, then sometimes the job can get easier. Going through a divorce in this profession can be a really draining time where a therapist might be helpful. So there are lots of different reasons that a therapist could be helpful besides critical incident stress. The normal everyday problems with the death of a parent or the death or illness of a parent, the death or illness of a spouse, marital problems, children who are having difficulty in school with learning disabilities. Therapy can help in those ordinary life experiences as well as be helpful with critical incident stress.
Here's a loaded question. Does therapy work?
Yes, it does. I tell my clients it's not like getting a massage. You're not going to feel better in 50 minutes, but eventually talking about difficulties does help. It's not a miracle cure. It's not magic. It won't work overnight. It needs to be put good effort into it. You will get out of therapy what you put into therapy. If you are not telling your therapist about your critical incidents, about your alcohol use, about your gambling, then you're not going to get very far. But if you put your cards on the table, then the therapist can help with what you bring. Therapy doesn't work by itself. You have to give it a sustained effort and combine it with things like alcohol abstention for 30 days. Give up alcohol for 30 days while you're trying counseling. Get exercise. Research is full of studies where exercise makes the most difference in depression and anxiety and other difficulties, especially cardiovascular exercise. Therapy is not exotic. It's not the end-all be-all. It's not for the weak people. It doesn't mean that you're damaged. Police officers have an FTO, somebody to show them the ropes. A therapist can be somebody that just shows you the ropes on how to deal with depression or critical incident stress. A therapist can be just another tool in your toolbox. Therapy's not forever. Once you start therapy, you're not going to have to be in it for years and years. It can be time limited. It can be set on the goals that you think are important along with your therapist or your family if that's what you're pursuing. So it's very helpful.